It's my great honor to be at CCOT and be a guest of Professor Look and the organization, and also very good for me to come to this part of the world to understand the culture and the people around here. The first time I've been in the Emirates area. So today I'm going to talk about innovation in sport medicine. It's the latest, always the greatest. I have no conflict of interest in this presentation. And like I say, I want to thank CCOT, especially Professor Look, who I know for a long time as I was from Hong Kong and went to America about 42 years ago. My department in Pittsburgh has been 102 years old. There are 5 professors. You may know some of them. Dr. Professor Ferguson, who is a great pediatric orthopedic surgeon, have trained more chairmen than anybody else. And Dr. Herndon, who was the AAOS president just a few years ago. This is where I live, Pittsburgh, Pennsylvania. And as you can see along the riverside, this is a sport complex where we see some of the sport injury patients. I want to remind everybody, we are now very fast-paced, one diagnosis, one quick surgery. Medicine is still an art. We need to spend time and think about patients. It's based on principle. So anything go against the principle will eventually may not work. We have many good ideas, but it may not be right principle. You have to work with the nature. If you want to, again, go against the nature and make everything the same, again, it won't work. Metal or metal hip, for example. And notice the pendulum should not swing on either side. It should be somewhere in the middle. You can sway each side. But extreme, you'd be cautious about. Now, my professor, Ferguson, taught me 2 important things in my life. First, he said, just do the right thing. It may be something very simple to say, but this a totality of all my education for my family, my high school, my college, my medical school, all together, do the right thing. And number 2 is take good care of your patients, and they will take good care of you. I think nowadays we're worried about healthcare changing in America, Obamacare, but I told my trainees, do not worry about it. If you really want to take care of a patient as your primary interest, it doesn't matter what you do. You'll be happy. So, what is innovation? In Latin, it means renew or change. It's the knowledge, it's the attitude, it's adopt or reject something, and then you have to implement and then confirm the result. Now, is innovation good? Now, I think if you look at what in medicine have done in the last 100 years, those are the 3 biggies in our field, okay? So these 3 entities allow us to move ahead in many things we're doing today. So I would say this is a really great innovation in the last century. Now, in sports, arthroscopy is important to make us look inside the knees and other joints, but also there are a lot of abuse with arthroscopy too. So we have to know that arthroscopy is good, but we are the master. We must use it properly. Also, reminding everybody in sport medicine, we're dealing with young and healthy patients. We're not dealing with cancer patients or patients that are really sick. So some of the principles used in cancer other treatment, I don't think we should be too quick to jump into sport medicine. We may see a bad effect on those. Now let's go back to 30 years ago. I was a very naive young surgeon. And I got a call from John Richmond, who was at Tufts at the time, and now he is the head of New England Baptist Hospital. He called me in '84, and I just started my faculty appointment in '82. He said, Freddie, I get 3 scientists from MIT. They invent a memory metal that you can put it into the bone. It's a one-way poke, and it's supposed to help to heal tissue to the bone directly. It's supposed to be simplify the operation. And I say, John, why do you want me to be involved?
I'm nobody, why you want to want me? He's, well, there's the guy, MIT guy daughter, go to school in Pittsburgh. And he wants you to help them to do this research because he wants to see the daughter, not because he wants me to do anything. So these are the guys. This are Jim Nicholson and Arthur Collis. So this is the MyTech G1 prototype anchor. Now, do you know what is MyTech? It's the tech from MIT. Even the head of DuPont did not know. I just gave a lecture not too long ago. So it's a tech from MIT. So it's a memory metal you put in and hook out. So we did all the biomechanical studies, some animal studies, and then we went on a clinical trial, did 32 patients, and we take a difficult operation, an open Bankart repair. Okay, so it's difficult to do technically, but the bone anchor allowed this to be much easier. So the paper went on, and we went through the American FDA, get approved, and it went on sale. Except the sales was low. And actually, the business side of the company then fired the scientists. He said, well, you guys are too slow, and we want quick return. So the product came along, 88, G1 anchor, G2 anchor, and the sales was lucky until the business side find a famous surgeon to use this. And this famous surgeon, his name is Dr. Frank Jobe, who 38 years ago invented Tommy John operation from the elbow. And he's a gentleman, really. He's not really a money going after guy, but he found this anchor to be very useful, and he know me personally, and he operated on this very famous player in America called Oriel Herschel, who's the #1 baseball player. And he came back to play the next year with an award. And since that time, the sales of bone anchor skyrocketed. So 92, 6 anchors, 96, 26, and a few years ago, 59 anchors, and I'm sure there are more by now. And basically, MyTech was sold to J&J for something like $200+ million for a $5,000 investment back in 1983. So I think it's an American dream. It's a very good story. The product works, and it's successful. Okay, so this is a good story. Now, I could have gone with MyTech, but I didn't. I still love what I do as a doctor. So I'm here as a professor, and doing patient care, and I'm still very happy with that. So this is it, okay? Global market, over $1 billion. Now, let's go back. So this is a good story. So why almost everything you heard about medicine is a little bit wrong? Because we are very enthusiastic to tell you positive results very quickly. But negative results take a long time to come along. In fact, we're not encouraged to publish negative results. So everybody likes good results. So there's a journal called Negative Results, by the way. You can go there and publish some negative results. Essentially, nobody gets promoted. No company will make money selling negative results. A few products right here. I'm sure some of you will recognize the name of this, product. Thalidomide was the drug used by Germans to treat morning sickness, and basically result in severe limb deficiency in some of the babies, and just make the U.S. Congress to use FDA start to monitor drug medications. So this is a good idea, morning sickness, but really with deficiting results. Now, some of you may not chemopap pain. The younger generation will never heard about that. Anybody know chemopapping here? Exactly. So we're the older folks. So in the 80s in Pittsburgh, where I work, there are 5 or 6 clinics do nothing by chemopapping, much like PRP today. Okay? And it's supposed to dissolve the disc, supposed to require no surgery, supposed to be a miracle cure. It takes a long time to find out it's not effective. And in fact, in America, they took it off the market completely in 2003 by the FDA. But it's still used in some countries in the world right today. Now, about 10, 12 years ago, as American and other people around the world want to do outpatient surgery, company tried to market on this and make money on this and say, well, this is something called a pain pump. You can put this pain pump around the knee, the shoulder, then you can go home, no outpatient, you don't have to stay in the hospital. But this pain pump causes control-lysis in young people. Look at this kind of cases. Essentially, Marcaine and all the, lidocaine are toxic to chondrocytes, especially around the shoulders. How about Vioxx? Now, there are two parts of Vioxx. The first part is this doctor called Scott Rubin, who is an anesthesiologist from Springfield, Mass., has published 15 to 20 articles, including a JVJS and level 1 study, and said that you should take Vioxx pre-op so that you will have less pain post-op. But you know what? Those data are completely fabricated. There were no patients ever being used, and he was only discovered by his local people at Springfield because he presented locally, and the local doctor said there's no IRP in any of this patient. So this is one on Vioxx. And number two is Vioxx also have a safety factors that it did have a heart problem in some people, killed some people. But the company decided not to talk about it for a while until the sales skyrocketed, and they have to take off the market. Now, even in chemotherapy, Avastin, which is the most expensive drug in the world right now, for supposed to have a very good scientific basis. It's supposed to shut down the vascularity for tumor, but it doesn't work in breast cancer. It took a few years to find out it didn't work because you know what? Cancer is smarter than any of us, basically. You think you know cancer. Cancer is supposed to kill us. This is why it's designed by somebody to do that. Okay, so medication may make sense, but not all the sense. So let's go back. Is the latest always the greatest? Let's go a few things in orthopedics, sport medicine, artificial ligament, thermal shrinkage, metal hip, matrix, BMP. Now the question is, what is market-driven and what is scientific-driven? I think we have to really distinguish that. Nowadays, many of these things are quite murky. We do not know because we heard everybody using it. It must be good. We must use it too. So that I would say is market-driven, not really scientific-driven. Now, in the mid-'80s, I put in about 50 or 60 this ligament, Gore-Tex graft. In fact, a few still works today. I have a patient that is still stable, but most of them don't work. Okay, there will be 3 or 4 days symposium, but on nothing but artificial ligament. It's great and fantastic. It's the front page of the newspaper. This famous athlete are back in 3 months playing sports. That's why you must use it. But you know what happened? When this thing broke down, it's horrible because these wear particles will interact with the synovium and cause severe synovitis and chondrolysis. And we wrote a paper on it in '88 to show that this is a problem. And artificial ligament has taken off the market except for a few countries. For a long time, this is the interaction, the wear particles. In fact, we did wear particles before the total joint surgeon started to look at it. Rubash, my partner at the time in Pittsburgh, actually started with Zimmer working on wear particles after we started. Work with the synovium, and then with IL-1, interleukin, going to kill the chondrocytes. In fact, at the time, Chris Evans and Peter Whaling, also in the lab. Peter Whaling will come back later, so he knows about this mechanism. This is why he's using the same thing right now in Germany. So this is a 20-plus years odyssey into this wear particles and chemical imbalance in people. Now, 20 years later, artificial ligament came back. The last ligament in France come back to China, Italy, and Australia. Except Australia already find the same problem. At least in 20 years ago, severe reaction. So again, if you go against the principle is artificial ligament will break down. If it breaks down, there's wear particles. And there's wear particles, there's problem. So unless you can eliminate that loop, it's going to happen again, okay? Now, how about thermal capsule shrinkage? So the idea is interesting because if you use heat, you can make the collagen fiber to cross-link closer together, and hey, it's tighter, so it won't dislocate, something like that. Except they forgot the shrinkage actually killed all the cells. So the linkage become non-biological. So with time, it's going to stretch out, have a problem. I remember 15 years ago, I was a member of the Shoulder Elbow Society in America, and this argument that every shoulder should be shrinked. Everyone. Okay, famous surgeon. All right? And the company Orotech was pushing hard. And basically, a lot of people use it, but then we see recurrence of instability, problem, neurological problem. So I don't think shrinkage is ever used now in shoulder reconstruction. Maybe from other aspect, of surgery. You know about the metal? I think Sir John Charlie, I was told, I never met the man, but he was real critical on everything. He still always worried about his results, always looking at his X-ray, is it good enough for me? Except his results are pretty good. We try to do more like this metal hip, which is, I understand, is because we want to do a hip that won't dislocate and won't give problem, but it's start to wear out. And in America, it's hardly used anymore. So essentially, you can see the Lancet. The failure rate of metal is so high that it cannot be implanted. Now, matrices is a good idea. So if something gets broken, biologically, if you can replace it, it's a wonderful idea. A few problems, because matrix essentially do not have mechanical strength, a lot, to hold things together. And if you're going to enhance healing, if it's from human, it's okay. Synthetic, it may break down. Animal can have immune reaction. So you can see those are the issue. So I think years ago, there's a substance called SIS, and I think its market is called Restore, and it's supposed to help rotator cuff repair. Put it on, sew it on. Since the cuff does not heal very fast, this substance is supposed to, assist healing. In fact, about 10 years ago, the sales of Restore was close to $80 million a year. And then George Morrell from Australia, the first to report that they see immune reaction in about 20% of the cases he have done. First report. Followed by Cleveland Clinic, same idea. So essentially, the study showed there's no improvement of SIS and there's complications. So nowadays, I think not many people are using matrices, at least for shoulder repair. Maybe for something else, maybe for cartilage and something else. Except now, SIS has a new name. The new name is called extracellular matrix, and now being tested in muscle healing. So it's a sorry start again, basically, by the same scientists and different company, basically. Okay, so you have to watch out. Now, how about BMP2? Dr. Luke is a spine surgeon. It's called Infuse. I know the company is right here, Medtronic, big, powerful company. But basically, in the spine journal, Dr. Kang looked at many of the paper published, and there are a lot of argument. Any industrial sponsor, paper that are surgeons that have conflict of interest, report no complications. But any independently studied paper show the complication of BMP2. It's a big thing in America right now, okay? Some of the surgeons receive up to $20 million US, 5 of them, okay? A lot of money, okay? So a lot of money involved, so it's hard to really write something negative about it. So bring it back to what are we? We are doctors. We're supposed to take care of patients. So in America now, the orthopedic surgeons and the psychiatrists are the ones that always be questioned by New York Times, Wall Street Journal. Our credibility is not very good. We are money hungry. We want just money. We don't want anything else. This is what we are portrayed many times. So we have to think about it. We have to change our image. Maybe not in your country, but in America. Really neurosurgeon, orthopedics, and psychiatry are the worst, in terms of getting conflict of interest problem. Now let's go back to evidence-based medicine. This guy, Paul Guyette, in 1992, in McMaster University, coined the term evidence-based medicine. And recently, I was with him in McMaster, and I gave a lecture there, and he gave a lecture.
And he said, is evidence-based medicine really evidence-based? What it means is the evidence-based medicine is designed as a level 1 study, but the data fit into the study may not be real. Can be made up like Dr. Screw-Rubin. So this is the paradigm. Improved patient outcome come from clinical expertise, come from patient value expectation, and then come from the best available clinical evidence. Now, except Dr. Bergfeld have think that we changed it since the MyTech, event. So it's a famous surgeon, a famous player, and now in America, there's a wounded soldiers too, because there's so many wars now. If you're wounded soldiers, you get sympathy too, a lot, okay? And new treatment. This is what you're going to sell a product very quickly. Henry Mencken, you know Henry Mencken, he is from Pittsburgh, Pennsylvania. He went to our program, became Harvard chairman. And many years ago, he said, you must know what is a placebo effect. Because years ago, when the doctors have nothing but a head, he will go to a house and say, okay, I talked to you for 20 minutes, but good day, ma'am, and you feel better tomorrow. This is all they can do, and you may feel better. I noticed it in 1986, where I became the head team doctor for the University of Pittsburgh football team. First thing I noticed is their oxygen tank over the field. I say, why do you need this thing? And all the players will come out from the field and say, okay, I feel better now. I'm ready to go back to play, okay? So we did all the study, a lot of literature, show that if you are on Dubai, you are sea level, you're 100% saturated. You cannot go anymore unless you're playing in Tibet or somewhere like that you may need some oxygen. But otherwise, in Pittsburgh, you don't need oxygen. Everybody is pretty much saturated. It took me 10 years to get the oxygen off the field because the coach and the player all believe it's good. Now, how do we treat the knee? Steroid actually calm the synovium so you feel better. Does not address the primary cause of the problem, which is arthritis and things like that, okay? This Henry Mencken already saw that actually is show a problem to the cartilage. So all this orthobiological we're talking today in terms of PRP, growth factors, stem cells, are all attacking some part of this chain right here. In America, it's a quick fix. All these things, you can cure everything from hair loss to sexual problem to anything with all these things, okay? You can find somebody who will take care of you. So if you have something like that, you know it probably doesn't work in most cases. Maybe it's in some cases. And like anything called hep cycle, anything will be extremely high, come down, and maybe it'll disappear, some of this, like chemopet pain. So we can always learn from history. How about gene therapy? You know about gene therapy. In fact, I was at the hot hub of gene therapy with Chris Evans and Jim Herndon 20 years ago. So the idea is we know that IL-1, interleukin-1, is a key substance that causes destruction of the synovium and cartilage. So if we can suppress IL-1 by gene therapy, like in rheumatoid patient, it seemed to be a good idea. The idea is to have the virus vector carry the gene into the cells to secrete the IL-1 suppressor, interleukin-1 receptor antagonist. In fact, Dr. Herndon, my boss, chairman before me, and Chris, now at Harvard, did a first study in 10 rheumatoid patients. Front page of New York Times about 94. It's a big deal. You know, everybody talk about gene therapy, except then people start to die. There are 2 from France and 1 from Philadelphia from virus, immunology from the virus, except if the gene therapy actually changed the genome and caused leukemia. So it stops right away, okay? Because actually it can kill some young people. How about PRP? Supposed to be the most promising, thing in the world, and I think people are using it. I'm nothing against it, okay? But the biggest paper from America on PRP is from New York Times a few years ago, because our player Heinz Ward had the PRP and then played 2 weeks later in the Super Bowl. He played 2 plays. He didn't do anything, but he played. So it's all over. Say that he had PRP. Now, interestingly, on your left side, you can see a player have no PRP 2 years earlier. His name is Plexible Burst.
He actually scored a winning touchdown against the Patriots. He had the same injury as Heinz Ward, a grade 2 MCL tear. And Dr. Warren just taped him up and gave him some cytokine, and he played too. This one have PRP, and he played, but he did not score a touchdown. So for me, the one without PRP actually scored better in these cases, okay? They score a goal. So 2,000 growth factors, some are good growth factors, some are bad. Are growth factors all beneficial? No. TGF-beta at 3 weeks after muscle injury actually causes fibrosis. Are all PRP the same? No. There are many preparation, variable between all of you sitting right here, age variable. We did prospective cohort studies in February JBJS. Some favor and some disfavor, so there's no clear touch whether it works or not. The IOC say we should proceed with care. Is it safe? Everybody thinks PRP is safe. Let me show you some example. First, a basic science study showed PRP can potentially cause inflammation in normal tissue in animals, in rabbits, okay? These are cases from Pittsburgh sent to us that essentially, after 2 injections, patients start to get osteolysis. Another one from Slovenia shows severe, extension of the patellar tendon. Another one I've seen myself, a bicyclist, both sides done, severe enlargement of patellar tendon. After about 1.5 years, start to get smaller. This one from Brazil showed complete disappearance of the Achilles tendon. So potentially, you have to tell the patient, when you put a PRP, that there's potentially harm. In some cases, not all the cases. This is why there's so many variables. But the PRP market is big, $126 million by 2016 without a lot of science. So basically, hey, I am Freddie Fu, I'm nobody. I cannot compete with $126 million. But I'm telling you about this, okay? In America, there's only 2 National Institute of Health grants on PRP research. So not many high-end research on PRP. Now, how about autokine? I don't know if Peter Willing is here, but this is from Germany. Like I told you, Peter Willing was a fellow and understand IL-1 is a bad thing, and he actually have a good scientific basis to suppress IL-1. So we put on Kobe Bryant, fed couples, as well as the Pope, okay? And it works in some of these cases. The question is, does it really work? Again, it's supposed synovium. Now, interestingly, the paper from Saris, who is the ICRS president from the Netherlands, showed that it doesn't work. Maybe work for 2 weeks and that's it. But the same, study come from, Peter Willing group showed that it works up to 2 years. So I'm not sure if it's a conflict of interest or what, but it's the same design study, both high-level one study, 200-plus patients. So it's a nice design study. So one say it works, same journal, good journal too. So who do you believe? It works or doesn't work? How about stem cells? Again, in America, they say you can use stem cells to treat everything. Rotator cuff surgery, ACL surgery. But stem cell actually come from blood vessels, now we know, okay? So it doesn't come from really one organ all around the vessel. So actually, you have stem cell yourself anytime. My whole point is you got it. You got PRP too. You can call, the police and this will come, call your own police department many times. Now, stem cells, we have looked at stem cells for many years in our lab. If you culture stem cells, after a few months, it can become cancer cells, some of them, okay? So you remember, stem cells and cancer cells are very similar. It's just one go to the dark side, one go to the good side. And culture, stem cells can become cancer cells. So we don't know which is a good or bad one if you watch this kind of movies, okay? How about CryoLife? You know this company. It's supposed to preserve cells, okay, in culture. So when you get a cartridge implant, it has cells in it. Except my partner, Connie Chu, did a biopsy of an $8,000 cartridge implant and found only 10% of the live cells in it. CryoLife doesn't exist anymore because this technology really is not true. Okay, it cannot preserve 90% of cells alive. So conflict of interest, like I say, there are big 5 doctors, lot of many doctors do not disclose. 30% in America do not disclose there's conflict of interest.
in JBJS. So, in conclusion, Dr. Kim, who is now the president of World Bank, he said that we are making the same mistake in global healthcare that we make in the American system, believing that better diagnosis and therapeutic tools will solve the problem. They won't, they haven't. We need measurement results well enough. In other words, we need better outcome measurement. We need to talk to a patient. We need to see exactly what works. Finding no difference does not mean no differences. It means that we have to look for differences. We need to strive for better outcome evaluation. So in 1952, there's a guy named Salk in Pittsburgh. He developed a vaccine to save the world. He had no patents on it. He gave it to the world free of charge. And people are safe even today on polio. So essentially in medicine, we cannot talk about fake innovation. We need to stop glorifying ourselves every new technology as innovation. New matters only when it proves better than what we had before. So in conclusion, ladies and gentlemen, innovation is necessary for continued advances in healthcare. However, innovation needs to be supported by evidence, both basic science and clinical, not market-driven. Progressive healthcare requires publication of both positive and negative results. Positive results should be independently verified. Even what I write about double bundle, somebody should show that it's worked, really. Don't believe what I wrote. I won't believe it until somebody can repeat my results, basically. On the other hand, we should not be a dinosaur and do nothing about it. We should dream, we should think, we should innovate, but also we'll be cautious. So thank you very much, and thank you, Dr.
Thank you very much, Dr. Fu. I'm sure you would agree with me